right, good morning, everyone that is signing on to the MSV and Virginia Department of Health webinar about COVID-19 vaccination. We will start in just a moment. And of course, the standard Zoom housekeeping. We'd like you, if you do have questions. Now, we have a whole bunch of questions we are going to ask our panelists, but I ask that you use the chat function for questions, not the raise hand function. I think it'll go a lot better that way. And of course, everyone, please mute if you would be so kind. And anyone that knows me from the MSV as former Speaker of the House, we will start on time, and the computer said 8 o'clock. So welcome, everyone. This is the Medical Society of Virginia and Virginia Department of Health webinar about COVID-19 vaccinations. So we have our panelists today, Dr. Lillian Peek, Director of Epidemiology in the Virginia Department of Health. We have Dr. Kosti Sifri, Professor of Medicine and Director of Hospital Epidemiology at UVA Health, Divisions of Infectious Disease and International Health, and co-chair of the Virginia VAW Safety and Efficacy Subgroup. And also Dr. Tezon Bell, Assistant Professor of Medicine, Division of Pulmonary and Critical Care Medicine at the UVA School of Medicine, and Director of the Medical Intensive Care Unit. So I'm Dr. Art Vayer, your MSV President. I'm the moderator today. So off we go. So as we kick off this informational panel, I think it's good for us to review where we are with the numbers. As of the 5th in this country, we have over 20.7 million positive cases, more than 350,000 deaths. In Virginia, the statewide positivity rate for PCR testing is about 16%. So panel, can you kick this off with your thoughts on the implications of these numbers?
I'll go ahead and start. I think this is what we've been concerned for and anticipating, since we first learned about the spread of this virus from Wuhan through China and then internationally back in the spring. So here we are less than a year later, and we're seeing what we were concerned about, which was a surge in infections during the cold and flu season, now the cold, flu, and COVID season. We think enabled in many ways from how transmissible this virus is, particularly indoors, particularly in times of when people are asymptomatic or pre-symptomatic prior to infection. And now I think built upon 9 months of pandemic fatigue. And then I think the final thing that, of course, we're reasonably concerned about, I believe, is that this is occurring after the holidays, and when there's been a lot of social gatherings, a lot of families, some extended families gathering. We know sort of from mobility data that it has been a very highly mobile time of year. And so while we're in a difficult situation right now, experience has told us, taking a look at surges that have occurred at other places across the country, and some of our earlier surges, for example, in the fall and in the spring, that these have a life cycle. A wave that often lasts about 2 months or so. So we are on the upswing, and I think that we need to anticipate that this will be a difficult January and at least part of February. Those are my thoughts.
Thank you, Dr. Sifri. And to set the stage for the importance of the vaccine, can you discuss the steps we need in place for an effective vaccine program to produce herd immunity, and any estimates on how long it will take to get to herd immunity in the United States?
Well, I can take that one. The concept of herd immunity basically means that there's a large segment of the population who's vaccinated, such that people that do not have protection, either because they have not got vaccinated or were unable to, or they haven't been infected, they have protection too, because there's not people around them that cause infection. I'll first say that number is not entirely clear for this disease, but most experts think that it's going to be north of 75% or so. Dr. Fauci has been quoting 80 to 85%, and has noted that he's kind of inched that number up as time has gone on. I think the what experts have said is that the ceiling for this is probably 90%. That's the rate at which measles attains herd immunity, and measles is more contagious than COVID-19 or than the coronavirus. But we do think it's going to be in that high sort of range. So it will be important to make sure a large segment of the population is vaccinated. That means we need to work on all the issues when it comes to manufacturing and distribution. The manufacturing has been slower than it needs to. Pfizer and Moderna have both contracted with companies that have a collection of around 5,000 job openings around the country. And they're not able to do a 24/7 operation, which is what we really need to boost production. And then we all know the issues when it comes to distribution, where it's hard to match supply and demand in many cases. We need to expand the workforce that's able to vaccinate, because in a lot of instances it's placed on healthcare workers who are already under strain from dealing with the coronavirus surges in their hospital systems. So we do have a lot of issues, but we have levers that we need to pull pretty much at every decision point.
All right, thank you, sir. All right.
I'd add a couple things to that.
Sure.
One thing now that is making this more challenging are the variants that we're seeing appear. The UK variant does seem to be more transmissible than what we're seeing in the US. And so that is going to put pressure on us. At this point, CDC is saying it's probably less than 0.5% of the cases here in the US, but we saw how quickly that spread in the UK. So it is something of concern and something that we're watching. And it is a bit of a race, because the vaccine, we need to get the vaccine out before there's a peak in the epidemic curve. And so it really is critical now that we work as quickly as we can to get people vaccinated.
All righty, thank you. And we all know that the majority of healthcare workers in Virginia are eager to be vaccinated. So, and I'm a Centera employee, I've already gotten my first dose, but how would physicians in private practice and their staff access the COVID-19 vaccine?
I'm probably the best one to take that one. So we recognize that this has been a challenge for providers that aren't part of a healthcare system. And we want to make sure that we're working with you to rectify that and to improve that. And we're sorry that it has been challenging for some of you to get the vaccine. So our strategy in Virginia has been for healthcare systems and local health departments to partner together. And in many parts of the state, the healthcare systems do have the capacity to help vaccinate those that aren't part of their health systems, and that's happening. And so that's working out well. In some other parts of the state, cases are surging, healthcare systems are under tremendous pressure right now, and it's been more challenging for them to assist. And so the local health departments are doing everything they can to try to gear up. You can imagine, even with the planning that we've been doing from the logistics, we didn't know who the priority groups would be. And it's in a very short time, everything came rolling out. And it is a challenge for the local health districts to be able to reach out to all of the different groups that are in these priority areas. So I ask you, if you haven't been able to get access to the vaccine, do reach out to your local health district. But just if you're having any challenges, we have a call center set up at VDH and we can help connect you. So just try not to get frustrated, and we'll work through this together.
All right, thank you. And would there be a different process for those healthcare workers in the long-term care setting?
Yes, the vaccinations in the long-term care facilities, for the vast majority of those in Virginia, they are getting vaccinated through a federal long-term care facility partnership. And so the CDC has partnered with CVS and Walgreens, and we have activated those contracts in Virginia. And both residents and staff in long-term care facilities will get vaccinated on site at the long-term care facility by those teams that are going into the long-term care facilities. And that now is, we now activated, so it began in the nursing homes, And now we've activated the contract to start in assisted living facilities and the other types of long-term care facilities across the state. And so we'll start to see those vaccinations as well in January 11th.
Oh, excellent. Okay. Now, we know some people are concerned that the vaccine was approved so quickly, while other vaccines have taken years for approval. So can someone tell us about the process and how quickly it was able to be approved, and any risks associated with the kind of emergency approval process versus full approval?
Yeah, I'll go ahead and take that because that was a significant question, something that we looked at very closely on the subgroup that I served on and I chair for this vaccine advisory work group. And I think it's probably something that we're all going to have to discuss and anticipate when we're talking with our patients about this. So I think having some working knowledge of what this is really helpful in terms of the education for at least some of our patients. So I'll try to go through it quickly, but there are some important parts of it that I want to highlight. So the first thing is to understand is that the ability to develop, particularly with the focus of these messenger RNA vaccines, it is something that's been built on after several decades of research. So it's a new vaccine technology. People may be concerned about that because it is news. It's the first time in humans for a clinically authorized and eventually licensed, we anticipate, vaccine. So there may be some concerns about that. But we've been looking at, collectively, scientifically, the scientific community have been looking at these types of vaccines for several decades for treatment of and prevention of infections of a range of different infectious diseases as well as cancer. And this is one of several platforms now that are very amenable to sort of a plug and play approach to vaccine development. So, we're on the 1-year anniversary of the discovery of this virus. It was announced in Wuhan on listservs on December 30th or 31st last year. And about 10 days later on January 10th, in just a couple of days from now, we'll have that anniversary. The genome was published on GenBank. And within 60 days or around 60 days, if I remember right, maybe 66 days, the target sequence for the glycopeptide spike protein was in clinical trials in this messenger RNA vaccine. So 2 months, just simply amazing. And so that technology, the development of that technology enabled, through modern research is what was able to help accelerate the development of the vaccine. But it's also been built on understanding of coronaviruses that have been built, again, also for the last couple of decades. So the experience with SARS, COVID-19, and then MERS, formed the basis of understanding of the importance of the spike glycoprotein for protective immunity. So knowing coronaviruses and understanding some of these modern platforms like messenger RNA, the clinical researchers were able to, and vaccinologists were able to use that to develop a target for an effective vaccine. And the vaccine approval process, I think, is important to understand. So the first thing is that they were put under the umbrella of Operation Warp Speed. And so with Operation Warp Speed, there was the use of a clinical trial network, 4 clinical trial networks stitched into one, leveraging what were already NIAID and other funded programs to develop vaccines, and put them under one umbrella with the same endpoints, with the same measures of efficacy and safety. And also what will become important is outcome measures of understanding what, like, secondary endpoints, biomarkers of immunity, all under the same process. And perform the vaccine trials. And this is not only true for the Moderna vaccine and then some of the other vaccines under development. They did it with the same data safety monitoring board. And then once going through the clinical trial process, the submission of those data were performed and went to 2 other independent groups. So the first, the FDA, and their independent advisory committee, the Vaccine Advisory Committee, or VRBAC, and then finally a review by the CDC and their independent advisory committee, ACIP or ACIP. So we have like 3 independent groups with vaccinologists, immunologists, ID doctors, statisticians that have reviewed these clinical trials at the same time. The other final important thing to highlight with this approval process is that there was a commitment to purchase vaccines before the results of the vaccine clinical trials were understood. So investments were made in manufacturing, so diversion of other manufacturing resources were made at these companies with investment of hundreds of millions of dollars. And the commitment to buy these vaccines. And if the vaccine trials had failed, if the Moderna and Pfizer vaccine showed that they were not protective, all those doses that were manufactured would have been thrown away. Essentially what has occurred is that in between steps between preclinical trials, phase 1, phase 2, and phase 3, those were cut out of the process. They shortened up those periods so you didn't have to, the companies didn't have to find funding, do evaluations, wait for a couple of years, and then start phase 2, do that again, and do that phase 3. They were able to do it at one fell swoop, and we had in the parallel process the manufacturing of the initial doses of vaccines at the same time. The second point of that is, how does an EUA, this emergency use authorization, differ than a licensed vaccine? The most significant difference is just the duration of follow-up. So these clinical trials are still going on. We're still tracking to see what happens to the people that were vaccinated, versus those that received the placebo. Those clinical trials will continue till they're completed. They're actually the part of the logistics of what to do now is where to go after the authorization in terms of dealing with those who receive the placebo. There are some modifications to the trials that are being discussed, but the long and the short of it is that what we will see is once the clinical trials receive sufficient amount of time, 6 months or a year, those data are going to be compilated, and then it'll be reviewed again by the FDA for approval as a licensed therapeutic.
All right, thank you, Doctor. And if we could just switch gears a little bit about the handling and storage. Why so cold? And why do these things have to come in on dry ice?
I can take that. I'll take a crack. I think maybe Tyson looked like he was ready to answer it too. So importantly, messenger RNA is a very, very fragile molecule. If anybody spent any time in the lab, it is one of the most difficult things to work with. I've done messenger RNA studies, and they are some of the most challenging that you can do in the laboratory. So it is so fragile that it really needs to be kept under these cold conditions. Now, why ultra cold, -80 versus -20? I'm not entirely certain with that, but I think some of the speculation I've heard is essentially that Pfizer, because of the rapid nature of approval, did not go through the same sort of pharmacologic evaluations in terms of immune response with the -20 degree held product versus -80. That may come in the future, but that is a little bit of speculation. But clearly, messenger RNA is a fragile entity. That's maybe also something when we talk about safety concerns for our patients is important to highlight.
All right, so once it's out of the super duper cold environment, how long is it good for?
So for the Moderna vaccine, that can be frozen for up to 6 months. When it's refrigerated, as long as the vial isn't opened, you can keep it for up to 30 days. But once it's opened, it has to be used within 6 hours at room temperature. And then after that, it has to be discarded. You'll probably mostly use Moderna.
Okay. All right. So as vaccines are coming to Virginia, to which locations are they being transported? And obviously, do we have enough of these ultra cold freezers?
So just a little clarification, it's only the Pfizer vaccine that has to be kept in the ultra cold freezers. The Moderna vaccine is handled like other frozen vaccines. But we have to figure out how to use both. And so far, we have had enough health systems that have the ability to work with the Pfizer vaccine. We're also using the Pfizer vaccine with the pharmacies that are doing the long-term care facility partnerships. So right now, we definitely have had the capacity to manage what we've received with Pfizer. So the way it works is we're not bringing it into one place in Virginia. whichever entity is receiving the vaccine is distributed directly to them. And then we do have some hub and spoke models. There are some health systems that are bringing the vaccine into one place and then redistributing it. And we can do that. We can redistribute the vaccine once it's received.
All righty. All right, so let's talk about who should be receiving this vaccine initially and how we're determining the tiers for vaccination. So if one of you could expound on that subject.
Okay, so right now we're in this is being done in a phased approach, and right now we're in phase 1A. And for phase 1A, that's healthcare personnel, and it is also residents of long-term care facilities. So when the Virginia Disaster Medical Advisory Committee that provides recommendations on how to allocate the vaccine in Virginia first looked at this, they did prioritize the vaccine in 4 levels for Virginia. We now, that's now, as of yesterday, I would say, those groups are now gone. So the recommendations now is let's get the vaccine as quickly as possible to anyone in phase 1A. So we've had now over 3 weeks to go through the order, and we're hopeful that most of the frontline healthcare providers have received it. So now it's really all hands on deck. Let's vaccinate everybody we can in phase 1A. There are actually some areas of the state that have done that and are ready to move forward. So the next phase that was approved and announced yesterday by the governor is phase 1B. And that is for frontline essential workers. I might, because this is interest, I could share my screen right now and take you through this so that you have access to the site if you want me to do that.
Sure, go right ahead.
Okay, so we've tried to put a lot of resources now on our website for you. And when you go to the vaccine website, at the VDH vaccine website, it now has each of these tabs to show you exactly what phase. Right now we're in phase 1A. We will be very shortly going to phase 1B. And so I'm going to just click on here to show you. This spells out who the different groups are in phase 1B. So it's frontline essential workers, and the groups are listed here. It's people who are 75 and older, and it's people who live in correctional facilities, homeless shelters, and migrant labor camps. And so as we're now moving into patient groups, it is going to be more important to engage the private providers. So each district is coming up with their plans for how to vaccinate these different groups, and they will be working with you all as frontline private providers to see how can we get your patients vaccinated who are 75 and older. We'll probably be working on a lot of closed points of dispensing for the essential workers, and certainly for people living in the correctional facilities. So the local health departments will be working with their partner health systems and healthcare providers to determine how to do this in their districts. Obviously, that's a lot of people. It's over 1.2 million people, maybe as many as 1.5 million. So after those are vaccinated, then we go on to phase 1C, which is another group of essential workers, people who are 65 and older, and then also people 16 and older that have an underlying medical condition that puts them at severe risk of COVID-19. So when we get to this part, obviously, you all will be doing a lot of the vaccination. That's where we'll be working with you to get your patients vaccinated. So it's important now that we work together to understand how we're going to get these older Virginians vaccinated, and that can help us work out the systems for them to gear up with private providers to do more people. It is challenging to the way the vaccines, they're multi-dose vaccines, so we do need to work out how do you provide the vaccine with how do you get the right quantity to have enough for your patients and there's none wasted. So I'll stop there. I could talk about this part all day, but I'll stop there.
Okay, let's move on a little bit just to special populations. So if one of you can comment on, should kids receive the vaccine? Should we be vaccinating pregnant healthcare workers or patients? And what about immune compromised patients?
So I can take those. As far as children, at the time being, the authorization for Pfizer includes 16 and up. And when I was 16, I did not consider myself a child, but I very much was. So with that caveat, 16 and up for Pfizer. For Moderna is 18 and up. Now, both of these trials have started enrolling children as young as 12 and up, I believe, and we'll have data released on that soon. Pfizer actually had started vaccinating children towards the end of their phase 3. The expectations that eventually younger children will be included as well once we have more data on these populations. But for now, the EUA is mostly adults. For the second part, vaccinating pregnant healthcare workers and patients, and this is something that has come up very frequently. I saw some statistics from the Bureau of Labor Statistics showing that 80% of our healthcare workforce are women, and a lot of them are reproductive age. So there are lots of concerns when it comes to potential effects on fertility, on pregnancy, and breastfeeding mothers. The American College of Obstetrics and Gynecology and the Academy of Breastfeeding Medicine, the Society for Maternal Fetal Medicine have all released statements saying that, one, they're frustrated that pregnant women weren't included in the trials, which is an ongoing issue, but that the risk of COVID-19 in the vast majority of cases will outweigh any potential side effect from the vaccine. We're not aware of any long-term side effects at this point. Definitely needs to be studied. But based on the technology from my messenger RNA vaccines, that these are products that break down relatively rapidly, but we know that COVID-19 is associated with higher rates of miscarriage, higher rates of preterm labor, more complications, that this is a population that should be vaccinated. And they made strong statements indicating that pregnant women, especially if they have risk factors for acquisition of COVID-19, should be vaccinated. So what we've been advising people is to consult with their own physicians, but pointing them to these society guidelines. Same thing for immune compromised patients. The American College of Rheumatology, Transplant ID societies have recommended for the use of these vaccines. Again, we don't have a large amount of specific data in these specific populations, but we do know that the risk of COVID-19 for immunocompromised patients can be associated with higher mortality and higher chance of complications. The good thing about the messenger RNA vaccines, and all the ones being considered in the United States at this point in clinical trials, is that they're not live vaccines, so they will not give you COVID-19. That would be a concern for these special populations, but that's not the case here. So on balance, the lean will be towards giving vaccination with making sure that patients with specific circumstances can speak with their physicians.
Okay.
If it's okay, I just want to amplify one thing, because one of my other jobs is I had an immunocompromised ID program. So an important part about immunocompromised patients that comes up is one of efficacy. So there's not a concern of safety, as Tyson just said. What does come up as a question is the efficacy, and those are going to require phase 4 clinical trials. But clearly, COVID infection in immunocompromised patients is devastating. So we are, as a community of ID practitioners who take care of immunocompromised patients, going to be certainly advocating for this vaccine quite strongly.
All right, excellent. And then one more special population question popped up. How about someone with a history of Guillain-Barré?
I'll go ahead and take that. So, Guillain-Barré syndrome is quite interesting. There are, as I think probably everybody is aware, recommendations if somebody's had a history of Guillain-Barré after influenza vaccine and shortly thereafter, within several weeks after influenza vaccination, to consider that as a caution for future flu vaccines. To date, I have not seen a report of Guillain-Barré syndrome for COVID vaccine. That may be something that will be determined actually as part of the VAERS report, sort of the reporting system after vaccination. So we'll see if there is a signal there. But as an ID doctor, what we also emphasize is Guillain-Barré syndrome can be a post-infectious syndrome for a wide variety of infections, including influenza infection. I also have not heard that for COVID itself, but I think more information we will look for, but right now no contraindication for people with a history of Guillain-Barré syndrome. And probably also worth stating, since it hasn't come up, some like allergies to like flu vax, to I shouldn't say about flu vaccine, but some of like latex or meat allergies or some of the other things that sometimes come up with flu vaccination.
All right, excellent. And in terms of the dosing schedule, Pfizer versus Moderna, does it matter which you get as a second one? Kind of what's the difference between the first and the second dose? And talk about the timing of the two doses, please.
So I can talk about some of these. The only difference between the Pfizer and Moderna is that if you start with one, you should stick with that one. So there shouldn't be interchangeability. These are similar vaccine platforms, the same technology essentially, but the EUA was used specifically with one product at a time. So is there that chance that someone might receive one and then receive the other by mistake? That's certainly possible. In that circumstance, I would expect that you would have the same sort of effect, but that should not be the plan, that we should just stick with the Pfizer, get the second Pfizer, Moderna, second is the Moderna. And then the second part, what's the difference between the initial vaccine and the booster? The initial is the same dose, but the difference is after you receive that first dose, you presumably have not had any response made to COVID-19, presumably you had not been infected before. And you make an initial response with antibodies and memory T cells, and that second dose serves as a booster, similar to other vaccines that have booster schedules. It's a reprime for the immune system to make an even more vigorous response. And so I received my second dose a couple of days ago. When I received the first vaccine, I really just had local injection site pain, but no other symptoms. When I received the second dose, similar to the clinical trials where there were more side effects reported with that second dose, I did have some more side effects. I had some headache and fatigue into the evening, and then overnight had some chills with no fever, and they pretty much resolved after about 12 to 14 hours or so, and I'm feel back to normal now. But that's the difference with that second dose, that it can induce a more vigorous immune response. As far as the timing of the two doses, the dose schedule for the Pfizer vaccine is 21 days, and for the Moderna, it's 28 days. I know at least for Pfizer, there's some leeway if there are special circumstances. If you receive it within 17 to 20 days, that would be considered the second dose. If you are beyond that, they just recommend to receive it as quickly as possible. As far as the last point, if at what point someone would need to start over and get vaccine number one again, I'm actually not sure. I'm wondering if CFI or any of the other experts are aware of that.
It's not recommended to restart this series. You just get the second dose as quickly as you can.
All righty. And then in terms of the side effects from the vaccine, and thank you for expounding on that, Dr. Bell, any role in the use of pre-medication with Tylenol or Motrin or anything of that sort?
I'll go ahead and take that. So, so the recommendations from the CDC are not to pre-medicate prior to vaccination, especially with like an anti-inflammatory like ibuprofen or Benadryl or anything else, but I think particular concerns about anti-inflammatories. The reason is that the purpose of the vaccine is to stimulate an immune response, and at least theoretically, blunting that response may be blunting the efficacy of that vaccine. So since it has not been studied, the recommendation is not to do that. However, there is an allowance for using it afterwards. I counsel people that if it is mild and it's something that's they can tolerate, that go ahead and avoid it. But if it is something that's too uncomfortable, I don't know if Tyson's experience with chills overnight sort of met that criteria to consider symptomatic relief with an over-the-counter.
All right, very good. And then how will adverse effects be monitored? And could someone discuss the VSafe and VAERS programs?
Sure,
And
I can-
tell us what VAERS is. I'm not familiar with that acronym.
Sure. These are systems that our pediatricians are very familiar with, but some of our adult medicine docs are not as familiar with. So theirs is the Vaccine Adverse Event Reporting System, and that is a system that's been in place for quite a long time. It is anybody can report symptoms or report into that system, patients or providers. And then, and that is really how we monitor. That's, I would say, the bedrock for monitoring vaccine safety in the United States. We have some other systems though as well, the Vaccine Safety Data Link and the Clinical Immunization Safety Assessment Project. And what CDC does with those programs is they work with a network of providers across the United States to then look more in depth at patient records and to try to understand effects of vaccines that way. So the new system that was created, VSafe, was just created for COVID-19, and it's a web-based system, and it has a smartphone tool with it, so it uses text messaging. So essentially, it asks people to do a check-in after the vaccine, and it does that, daily, and then gets extended out to longer periods of time. And so this is a way for CDC to collect, to more proactively collect information. And I think that Dr. Bell actually used it, so I'll let him comment on that to see how it worked as well.
Yes, it was a really good system, particularly because I would not have remembered to proactively log symptoms, particularly after the first day or so when the excitement wears off and you're just going about your daily business. But you get that ping at the same time daily at first to go ahead and log your symptoms. It took me about 30 seconds total to do it. And then it moved on to a weekly basis. And then on the 5th, when I actually received the vaccine, it actually pinged me and asked me, did I actually receive my vaccine? And I said, yes. And then presumably that changed the algorithm and I started getting asked questions a little bit more frequently. So I think it's actually a fantastic system. I've been very happy with it.
All right, excellent. And then how about the other vaccines on the horizon? The Astrazeneca, the J&J, and Novavax. Do we have any information on those yet, or time for rollout?
I can start with that. Others may contribute. So I think probably some of you know the Astrazeneca vaccine has been approved for use in the United Kingdom, and it's part of their vaccine response that's being deployed in England. And there's been a lot of discussion in the news because of some changes to changes to the vaccine schedule that have occurred in response to the strain that Lillian talked about earlier. That's spreading quickly, especially in southern England. So that is a vector-based vaccine, an adenovirus chimpanzee-based vaccine. Johnson & Johnson has a similar type of platform, a human adenovirus-based vaccine. Again, these are both targeting the spike glycoprotein. They're in the middle of their clinical trial. We haven't seen interim analysis from them yet. So we're anticipating that we should see that, sometime soon in the next month or so. So I'm waiting to see that. And then the Novavax is a third type of platform. It's a nanoparticle, so a protein-based vaccine. Clinical trials, the phase 3 clinical trials for that, I believe, started at the end of December. So, but the phase 1/2 clinical trials showed a very robust immune response, and actually these other vaccines have as well. They've shown that in vitro they're stimulating the type of immune response that Dr. Bell talked about earlier, not in terms of antibody response, including neutralizing antibody responses.
All right, excellent. And someone asked about the Sinopharm. Is that another one in the pipeline?
If I remember right, others can correct me, but I think the Sinopharm is one of the inactivated viruses vaccines from China. I think there's two, but I think the Sinopharm is the one that I remember, and I can't remember if that's from the group in Wuhan or Beijing, but it's essentially an inactivated virus. So grown, inactivated, and that's sort of the basis of the vaccine program in China. And if I'm not mistaken, I think that has also shown very impressive efficacy above 90%. The one thing I didn't highlight about the Adenovirus vaccine is that, and I'll come back to that just quite briefly, the vaccine efficacy for that is a little interesting. The overall efficacy was 70%, but in the clinical analysis, they found that there was they had two different approaches of doing the vaccine, sort of a half dose at dose 1, and then a full dose at dose 2. And again, it's a 2-dose vaccine. And that was compared to a full dose at dose 1 and a full dose at dose 2 due to some manufacturing issues. And they found that the half dose followed by the full dose was 90% protective, whereas the half dose followed by full dose was at 62% effective, or 64%. That's interim analysis. I think we need to wait to see what the final numbers look like, but it is an interesting phenomenon that it doesn't make a lot of sense, but people are interested. There may be some reasons for that.
All righty. And then last point that I have on my list, so-called vaccine hesitancy, because surveys completed have shown that anywhere from 1/3 to 2/3 of healthcare workers are a little bit hesitant to get the vaccine. So what can we tell them for moving past that?
So I can talk about this. So I think, when we approach this notion of vaccine hesitancy, I think we need to keep in mind that social psychology predicts that only a small segment of the population is going to be jumping in front of the line anyway. Many of us are not the people who would stand overnight in line for an iPhone. I get the same order of coffee. I don't even, change the food I get from my local takeouts because I'm just in that routine. It's only about 15% of people who will jump to the front of the line to get anything that's new. So it's not surprising that we have people that have questions, that have some concerns and have hesitancy, particularly when we've developed a vaccine, in a really quick time frame, when it's been developed with an administration that has not engendered trust. And it's something that's being injected into your body. So I think the first thing is just to normalize this concept that people are going to have questions about it. And hesitancy kind of implies that that we shouldn't have these questions, that we should just all be rushing to the front. So I think that's the first sort of thing to bear in mind. I think the second part is, similar to when you're in the hospital or in your clinic and a patient asks a question, there's usually a question underneath that question. So whenever you have a reason that's presented why someone may have questions about the vaccine or may not be excited to receive it, there are different sort of underlying issues, whether it's related to the technology itself, how it works, just having that understanding of it, the safety in pregnancy, fertility, and breastfeeding mothers has been a large one that we've addressed. And conspiracy theories, just to be honest, that a lot of people do believe in some of these conspiracy theories that are out there relating to microchips and bioluminescent materials in the vaccine. None of these are actually true. But someone who's famous and has a big following, just kind of propagates this, and it just kind of spreads throughout and becomes a concern in the community. And these are issues that we're actually dealing with when we're trying to educate about the vaccine. So I think, my approach has been to level the playing field and make it a safe space for people to address whatever issue they may have, because sometimes there are questions that people are afraid or do not want to actually bring up with their providers, but they'll mention it to their friends after you leave the room. I've tried to make it so that I get those questions when I'm in the room face to face and not after I walk out of the room. So you have to make it a safe space for someone to address what their actual concerns are. You need to dig deep, from that first question that you get to that underlying issue to make sure that you can address that and find out whether this is, conspiracy theory, whether it's an information gap and they have the wrong information, or they need reassurance on the timeline, reassurance for their particular condition. And then I think over time, I think as more people get vaccinated, healthcare workers and 1A workers on the front lines, and we see how efficacious this is and how safe it is, I think the general momentum in social psychology will predict that the standard deviation, the 1 or 2 standard deviations of the population will then follow.
All right, excellent. Thank you, Dr. Bell. All right, well, let's go on to some questions that we have from our participants here. I'm just going to kind of go down the list, and some of these may have been addressed partially, but if anyone wants to take those, feel free. So question one, when do we think vaccine may be available to occupational health clinics in private industry to administer to employees in non-healthcare critical infrastructure industries? Wow, like paper packaging, for example.
Sure, I can take that. So that is going to be an important strategy in phase 1B and phase 1C, as I just showed you. We are discussing now when we should go to phase 1B because there are parts of the state that are ready. So we'll be looking at that carefully over the next few days to determine when we need to move forward. As I said, the health districts are going to be reaching out to the providers to plan for that. So for example, some of those businesses that have occupational health programs, if they meet one of the essential worker categories, the health districts will be reaching out to those companies in their district to understand, how are we going to get these people vaccinated? And then the occupational health units can receive the vaccine. So if you have providers and you're signed up to be a vaccinator, then the vaccine can go to you.
Okay, and very specific question, 66-year-old patient, 2 years, no evidence of disease from lung cancer with a chronic MAC infection. Oh, that's my Microbacterium avium something, if I remember right. I'm a surgeon, so I don't stay up on that part. So what would be that patient's priority, and when could they possibly expect to get the vaccine, and from where?
I'll go ahead and take that. So it sounds like with age and also with comorbidities, this would probably be somebody that would fall into the 1C category. I may defer to Lillian a little bit about the next question, but it's probably reasonable to maybe think about the work ahead. As Lillian said, in 1B, with critical infrastructure, essential workers, and persons over the age of 75, 1.2 to 1.5 million people. And we're looking at maybe a month or a month and a half while things are ramping up to work through the approximately 0.5 million people that were part of 1A. It sounds to me like it'd be something that you'd have to anticipate would be, after February, whether that's March or April, I'm not sure, but I think that's what would be predictable. I'm really hopeful that as we learn how to provide vaccine and we learn how to do it quickly, and also maybe if we're leveraging opportunities like occupational health services that are able to vaccinate large groups of people quickly, in industry, that things will continue to see some speeding up as Governor Northam talked about yesterday.
Okay.
And a lot of that does depend on the supply. So we're really hopeful to get some more vaccines available to us. And once that happens, then of course we can ramp up much more quickly. We've also heard just estimates from FDA. I don't really know the denominator of vaccines that are available in the US. That hasn't been shared with states, but we have been told that we should have an increase available to some degree in January. So in about mid-December, we were told that we would be getting about 100,000 doses of vaccine a week for the next few weeks, like 4 to 6 weeks. So that gets us through, mid-January. We hope to see that supply increase after that, but that just depends on the manufacturer's ability to ramp up and to do that safely.
Okay, next question is, I guess, possibly falls under the long-term care facility federal program, but patient in a continuing care residential retirement facility, independent living with a daily aid that the patient employs. Is that part of that federal program?
Yes, the continuing care communities are part of long-term care facilities. They are not, they are allocated vaccine after the more like the SNFs are completed. So, but yes, those are part of the vaccination program. And most of those, it's probably a mixture. Many of those are going to get vaccinated through the long-term care facility federal partnership. Those that did not sign up will need to work with their local health departments to come up with a plan for how to get vaccinated.
Okay, and a couple questions on contraindications. If someone's fighting another virus, for instance, herpes virus, should they wait until that is cleared to take the vaccine?
I can take that. So the general recommendations for receiving any vaccine is that you're not currently actively infected with anything else. So my suggestion would be to wait until your immune system is done dealing with that threat and you've recovered before receiving a vaccine to launch an immune protection against the coronavirus.
Okay, excellent. And how about absolute contraindications to the vaccine?
So the only absolute contraindication is people who have a known history of anaphylactic reaction to one of the components of the vaccines themselves. And for the mRNA vaccines, those would be the lipid nanoparticle that includes polyethylene glycol, in addition to some of the sugars and salts that are in there, which you wouldn't expect someone to be reacted to. So obviously there's not been this technology on the platform or FDA license before, so we don't expect anyone to have the known history of this unless they've been in a prior clinical trial. But that's the only absolute contraindication. I think the confusion happens because we do have a lot of people who have history of anaphylaxis, whether it be to drugs or foods or other things. And if that is the case, the recommendation from ACIP is for that person to proceed with vaccination, consult your healthcare physician and professional, of course, but that they be monitored for longer than the standard period of 15 minutes, and they're actually watched for 30 minutes. So I was watched for 15 minutes because I don't have a history of anaphylaxis, but later when my son gets the vaccine, when he does have a history of anaphylaxis to several foods, he will likely just be monitored for 30 minutes.
Okay.
Can I tack on one thing from what Tyson just answered? And it's some new information that was published yesterday in MMWR talking about how frequently anaphylaxis is. So we've certainly heard about the anecdotal reports in the UK and then around the US as the mRNA vaccines have started to be deployed. So in MMWR yesterday, the VAERS reporting system that Lillian talked about a little bit earlier reported the initial experience with the 1.9 million doses of the Pfizer vaccine after it was rolled out. And with that, after that rollout, they identified a total of 21 cases of anaphylaxis or anaphylaxis-like reaction. So the overall rate was around 11 cases per million people vaccinated. Of those, the 21 people that had reaction, 17 had a history of having anaphylaxis. So there were some people, 4 people in that group that had an anaphylactic-like reaction without having a history of anaphylaxis. So that's important to note, but also again, to Tyson's point, 70% of people who had reactions, they occurred within 15 minutes of their vaccine, and all did well. Most people were treated in the emergency room. There were a couple hospitalizations. So trying to sort of right size it is important as part of what Tyson talked about in terms of anaphylaxis. If somebody has a history of severe anaphylaxis, that's certainly, I think, worth exploring either as a provider or to encourage them to see an allergist if they have that relationship.
All right, now a question on testing. If the messenger RNA vaccines induce the production of spike proteins in the nose or oral pharynx, and if the rapid antigen test looked for spike proteins, is there some predictable false positive risk to vaccinated people with the rapid antigen test?
Yes, I've seen Kosi take this question before, so I'll try to step in. There's not an expectation that you'll actually have a positive antigen test through the nasopharynx, mostly because the spike protein is produced locally, and I believe in some liver cells. Theoretically, there could be a crossover where it gets from the bloodstream into the nasopharynx. I suppose theoretically that's possible, but I wouldn't expect that to be the case. So you should have a positive antibody test because the antibody tests are looking for antibodies that are produced to the spike protein, but not an actual antigen test in the nasopharynx. Kosti, how'd I do?
You did perfect. With the one twist I'd put on it is that it depends on the antibody test. So there's different antibody tests. The one that we use at our hospital detects nucleocapsid. It depends on which antibody test. There are antibody tests, though, that detect the spike protein. So you'll have to know the test to know if you're going to have a positive antibody response.
All righty. Next question. Any special precautions need to be taken between first and second doses? And specifically, if somebody gets COVID between the doses, do they get the second dose?
Tyson looks like he's going to answer as well. I'll answer a little bit, but I'll say that we don't know, and I'd really be interested in hearing Lillian's take on it. So we have had this happen. We've had, I think, to my knowledge, 2 or 3 people who have developed COVID after the first vaccine and before the second vaccine. And it does beg the question, what do you do? So part of the cautions that Tyson talked about earlier about having an infection, one of those is if you have COVID infection, it is not recommended to get COVID vaccine. However, after you recover from COVID, then you can get vaccine. You can wait longer. You can wait, for up to 3 months. It's recommended before getting the vaccine because the likelihood of reinfection in that period of time is low. But in certain circumstances, if you have enough vaccine, go ahead and do it. And in certain situations, if you're high risk for repeated exposure, it makes sense to get it earlier. But to the point of what to do after the first vaccine and then you get infection, our current recommendation is to treat that as what I just talked about, as an infection, and then to develop a stance afterwards to resume vaccination or to restart vaccination. And I don't think there's clear guidance right now that I've seen, and I think we're probably waiting to see more than anything else what happens in this real world experience, what occurs after infection. So our current stance is to say exactly that. You still should get vaccinated. Since reinfection within 90 days is unlikely, there's not an impetus to do it right away. You can take some time. And currently, our recommendation is just to give the second vaccine, just to adopt the stance that you're getting a second vaccine late. But I don't know if we know what the right answer is.
Ready? And I'm going to ask, we had a couple questions on what is the name of the VAERS app or the vSafe app?
So vSafe, that's the app. And if you go to either our website, let me just really quick share my screen one more time. And last couple minutes, share some more resources with you. So I've gone to our healthcare professionals page, and I want to show you vaccine resources for practices. And if you go here, there's all of the different materials that you need for background and information to provide for both vaccines. And then what to expect after getting a COVID-19 vaccine does take you to the vSafe information. And so we are recommending that you give that handout to your patients when you vaccinate them. There's also the vaccination record card, and this is a screening form that you can use for patients. So all of the information that you need to provide the vaccine in your practice are there. Additionally, you go back, this is where you can also sign up to be a provider. Let's see, if you go back to the main page for healthcare providers, you can see enrollment, and here's the form that you need to do. You start with doing this provider intent form. So really encourage you to think about becoming a provider. We need all the help that we can get to get this vaccine out as quickly as possible.
Excellent. Oh, and Dr. Peak, if you could just scroll down a little more, just tell us about the upcoming webinar on vaccine safety that the VDH is going to be presenting.
Sure. Let's see. I think that was.
I saw it under events there.
Let's see. I'm only showing the ones, I'm only seeing the ones on January 7th. And I know we were supposed to talk about that, but I don't have the details in front of me. Do you?
Okay.
Let's see. 1 second. Sorry. We do have you can look on our website because we do have a presentation coming up. I believe, there you go, perfect. January 16th from 9 to 10. And this is specifically on the vaccine safety. And we have a great panel that's there to provide information for you. So we hope you can join them.
All right, excellent. Well, I'm sorry we couldn't get to all the questions, but as we wind down here, I'd like to turn the floor over to our CEO and EVP, Ms. Melina Davis, regarding the MSV's efforts in all this.
Hello, everybody, and thank you for participating. There were so many of you here. We have gotten a lot of questions about how to reach your health district. We do understand that they have very limited resources and are having difficulty reaching out to you, and as well receiving incoming calls. We've also learned as of yesterday that they really don't have the contact information they need for you. So we probably have the most comprehensive contact database. We take the Board of Medicines and we've supplemented it with any email addresses and zip code information that may be new that will be very important to the health district. So I'm asking all of you who are members of MSV to log into our website at msv.org and update your contact information, particularly your email and zip code. I also ask that you do the same with your specialty societies and your local component societies. We'll be working with them over the next 48 hours to try to pull together and dedupe all of those lists and give the health district something that they can utilize to reach you electronically and send you a link to schedule appointments to get your vaccines. We think this will be the most efficient way to do it. And tomorrow, tomorrow we're working with newly appointed Dr. Danny Avula to see what else we can do to support the effort. We know there's been difficulty, so please call us, write us, tell us what trouble you're having, and we will continue to work with VDH and solve for you. So hope that was fast enough, Dr. Vayer.
No, that was great. Thank you. And for any unanswered questions, Tim just posted in the chat, please send unanswered questions to govt, government affairs @msv.org. So we are past the top of the hour. Dr. Peak, Dr. Bell, Dr. Sifry, I thank you so much for being generous with your time. Thank everyone for attending. This was excellent information for us, and good luck to everyone getting your vaccine, staying safe, staying healthy, and to quote our past president, wash your hands.